Here are two lab panels. Both patients have identically elevated total T4 and total T3. On the left, a suppressed TSH confirms hyperthyroidism. On the right, a perfectly normal TSH is far more dangerous. Modern assays are incredibly precise, sensitive below 0.01, rendering older TRH stimulation tests completely obsolete. While these sensitive assays accurately reflect the pituitary's response, they cannot distinguish between a gland that is overactive and one that is simply reacting to shifts in peripheral binding or conversion. To accurately diagnose thyroid pathology, we have to look past the top-line numbers. We must track the hormones through three hidden variables: binding protein kinetics, tissue-specific diiodinases, and receptor isoforms. Because the pituitary responds to local T3 levels, a TSH result can often contradict peripheral reality. Understanding the thyroid requires resolving these contradictions by looking at how hormones are transported, converted, and received at the tissue level. 99.98% of T4 is locked on to transport proteins like TBG. Only 0.02% floating in plasma is biologically active. High estrogen delays TBG clearance. More TBG binds more free T4. The thyroid compensates. Total T4 rises, but active free T4 and TSH remain perfectly normal. We see a similar structural trap in a genetic edge case called familial dysalbuminemic hyperthyroxanemia, or FDH. An autosomal dominant mutation alters albumin to bind T4 aggressively. Total T4 skyrockets, triggering false alarms for hyperthyroidism on standard lab panels. If free T4, verified by equilibrium dialysis, and TSH are both normal, guidelines require withholding treatment. Binding protein anomalies manipulate the inert storage pool. They do not alter the active biological signal. In the very first trimester of pregnancy, the entire endocrine axis undergoes a dramatic and temporary structural hijacking. TSH shares an identical alpha subunit with HCG. When HCG peaks early in gestation, it directly cross-reacts with the TSH receptor. This unintentional stimulation generates CAMP. The thyroid releases excess hormone, driving a reciprocal feedback loop that forces TSH levels below 0.1. This biochemical cascade creates transient gestational thyrotoxicosis. Treating this HCG-mediated thyrotoxicosis with antithyroid drugs is contraindicated. The clinical intervention is simply IV fluids. As the pregnancy progresses into the second and third trimesters, central suppression resolves, and the focus shifts entirely to peripheral metabolic demand. Fetal development aggressively consumes massive amounts of maternal resources, as hormones transfer across the rhythmically pulsing, highly vascularized placental barrier. Because of this consumption, pregnant patients with pre-existing hypothyroidism require a massive increase in their levothyroxine dosage, often up to 45%. The mechanism is type 3 diogenase. The placenta expresses this enzyme, actively inactivating maternal T4 by cleaving it into dead-end reverse T3. This consumptive pathway also creates true hypothyroidism in massive hemangiomas and drives sick euthyroid syndrome in muscle and liver. Pregnancy stresses the thyroid axis at both ends, suppressing central TSH production early on while actively degrading peripheral T4 reserves throughout gestation. To understand how the system regulates itself through these extremes, we must examine the final feedback loop inside the hypothalamus and pituitary gland. The thyroid secretes 15 times more T4, but T3 is the true active ligand. It binds to nuclear receptors 10 to 15 times more avidly. Negative feedback relies on the TR-beta2 receptor in the pituitary. Without hormone, a heavy co-repressor protein sits on the DNA sequence, silencing transcription. When T3 docks, the co-repressor detaches, the DNA sequence activates, and transcription halts TSH production. This precision breaks down in resistance to thyroid hormone, or RTH. Patients inherit a mutation in the TR-beta domain. Mutant receptors bind the DNA, but stubbornly refuse to release their co-repressors, even when flooded with T3. The pituitary is rendered clinically blind to T3. TSH remains inappropriately normal or high, driving massive peripheral elevations of T4 and T3. Suppressing this compensatory hormone elevation with drugs is a severe error. The thyroid is merely amplifying its output to be heard by deaf receptors. These deductions form a strict algorithm. With TSH below 0.01, the immediate next step is measuring free T4 and free T3. If free T4 is normal, checking free T3 is mandatory. 2 to 5% present as isolated T3 toxicosis. But before diagnosing a hyperactive gland, you have to rule out a synthetic artifact, biotin. Excessive biotin intake, specifically over 1,000 micrograms, completely disrupts the immunoassay binding sites. It falsely suppresses the TSH reading while artificially elevating the T4 and T3 numbers. If the biochemical axis is pristine, but a physical mass is palpated, the diagnostic pathway pivots. Function becomes irrelevant, and structural risk assessment begins. The standard of care shifts entirely to high-resolution ultrasound evaluation. The baseline rules are strict. Functioning hot nodules are almost never malignant, but non-functioning cold nodules carry a 5 to 10% risk of cancer and require TRADS risk stratification. We look for specific sonographic patterns. A spongiform nodule or a simple cyst carries less than a 3% risk of malignancy. These absolutely do not require an FNA biopsy. Contrast that with a hypoechoic, solid nodule presenting with irregular borders and punctate echogenic foci, also known as psammoma bodies. This specific sonographic pattern carries greater than a 90% risk of thyroid cancer and mandates immediate biopsy. Effective clinical management requires integrating these biochemical feedback loops with structural risk assessments. A suppressed TSH or an ultrasound shadow gains clinical meaning only once the failure is traced to its specific molecular or structural compartment.